Welcome to this topic. This session is on a very important topic on anemia in pregnancy, which is a common presentation in our antenatal care. Mild anemia is a misnomer. Most iron deficiency is already advanced by the time anemia is detected. WHO and CDC recommendations defined anemia in pregnancy as Hb less than 11 grams per deciliter. Trimester-specific Hb thresholds for diagnosing anemia are: for the first and third trimester, anemia is considered as Hb less than 11 grams per deciliter, while second trimester, hemoglobin less than 10.5 grams per deciliter, and postpartum is when Hb is less than 10 grams per deciliter. Severity of anemia in pregnancy is categorized by the level of hemoglobin, whereby hemoglobin of 10 to 10.9 is categorized as mild, and Hb 7 to 9.9 is moderate, and severe anemia is when the hemoglobin levels of less than 7 grams per deciliter. Maternal anemia is basically anemia that occurs during antenatal period and postpartum. Women at risk for maternal anemia includes pre-existing anemia, grand multipara, poor spacing, multiple pregnancy, obesity, poor socio-economic status, and post-delivery complicated with postpartum hemorrhage. Tackling anemia is crucial to prevent postpartum hemorrhage and venous thromboembolism. These are the types of anemia that we can identify while reviewing their FBC, including the value of MCV, which is the mean corpuscular volume, as it could help us classify anemia into microcytic anemia, normocytic anemia, or macrocytic anemia. Today, we shall look into the causes for microcytic anemia, which include iron deficiency, anemia of chronic disease, alpha and beta thalassemia, and sideroblastic anemia. In this lecture, we will be focusing on iron deficiency anemia and thalassemia, as it is detrimental to both mother and fetus. Pregnant mothers are unable to tolerate blood loss due to their physiological hemodynamic changes, which can lead to risk of heart failure and maternal morbidity. Postnatally, it could also lead to reduced milk production and shorter lactation periods. In the fetus, anemia in pregnancy is associated with intrauterine growth restriction, small gestational age, and fetal growth retardation. It is also linked to premature birth, low birth weight, stillborn, and perinatal mortality. Long-term adverse effects on brain development includes autism spectrum disorder, attention deficit, and hyperactivity disorder. This graph illustrates the iron requirement during pregnancy, which is 9 times higher compared to non-gravid or postpartum women. This highlights the importance of prompt management of anemia in this population. The routine blood investigation for iron deficiency includes full blood count to look at the hemoglobin, MCV and MCH, as it can determine if it is hypochromic or microcytic, serum ferritin and transferrin saturation, which are part of the iron studies, and in certain cases, you might need to investigate for malaria and parasites. Regarding serum ferritin, it is frequently used to evaluate iron stores, and levels of less than 30 is considered low. However, our target of serum ferritin should be more than 100 in pregnancy. Transferrin saturation is also part of the iron study, and it indicates iron supply to support normal erythropoiesis. This value is the ratio of serum iron and total iron binding capacity for human body. Basically, higher transferrin saturation, the more adequate iron stores. iron deficiency without anemia, meaning with normal hemoglobin levels. Now, this is a new concept that we would like to highlight, as even in the absence of anemia, iron deficiency could occur, especially vegetarians, in women who is multiparous and poor spacing. Therefore, hemoglobin levels alone is not suitable to assess iron status, especially when there is various degree of hemodilution in pregnancy. Now, clues can be derived based on the low MCV or MCH, which then can be further investigated for ferritin and T-set levels accordingly. Hence, again, mild anemia is a misnomer, as iron deficiency is probably advanced by the time hemoglobin level is 10 to 10.9. The deficiency has consequences, even when no anemia is clinically apparent. Severe antenatal anemia, which was defined by WHO as less than 7 grams per deciliter, has been associated with abnormal fetal oxygenation and reduced amniotic fluid volume. It is important to remember high hemoglobin levels do not exclude iron deficiency, as it can be masked by failure for plasma volume expansion or other chronic diseases. Patient blood management has 3 pillars. The first pillar is optimizing erythropoiesis. Second pillar, to minimize bleeding and blood loss. And the third pillar is to harness and optimize physiologic tolerance of anemia. In the first pillar of blood management, we should be able to, first, improve detection and treatment of iron deficiency and IDA. Secondly, to optimize usage of oral iron and resort to parenteral iron if required. And thirdly, to look for adequate response of more than 1 grams per deciliter in 2 weeks or more than 2 grams per deciliter in a month. Oral iron therapy is being used for prevention of anemia and treatment. Actually, we can practice alternate day dosing, which may first maximize fractional iron absorption, increase dosage efficacy, reduce GI exposure to unabsorbed iron, and improve tolerance of iron supplements. The regimes for oral hematinics. For prophylactic dose, we can adopt daily dosing or every other day dosing. It is important to start with a higher dose of 60 milligrams elemental iron in view of high prevalence of anemia in pregnancy in Malaysia. So, it is important to start with at least zincophor in our antenatal mothers as prophylaxis. For treatment dose in iron deficiency anemia, use 120 to 180 milligrams elemental dose such as zincophor 1 tab daily, Ibret 1 tab daily, or maltopher 2 to 3 tabs daily. Please remember, avoid multiple doses per day. There's no more double or triple hematinics, and there's no weekly intermittent dosing. Iron replacement therapy. Apart from oral iron, we also have parenteral iron, which can be administered via intramuscular or intravenous, and the commonly used is cosmophor. Avoid administering via intramuscular as it has uncertain absorption rate, painful, and causes staining. Most importantly, parenteral iron is contraindicated in the first trimester. For us to be able to successfully implementing intravenous iron in health clinics, we should familiarize ourselves with risk of reactions towards it. It is assuring to know that the anaphylactic reaction is extremely rare and occurs mainly with the high molecular weight iron dextrin. The newer formulations are safer to be administered, either infusion over 4 to 6 hours or boluses of every other day. The adverse reactions are, firstly, infusion reaction or fishbane reactions, which are self-limiting, occurring only 1 to 100 to 250 administrations. It is due to labile-free iron. Some of the symptoms can be acute chest tightness or back tightness, myalgia, flushing, diarrhea, or swelling of hand or feet. It does not cause hypotension, wheezing, or stridor. It is considered minor reaction and is not a hypersensitivity reaction. To manage, re-challenge with a lower infusion rate or switch to IV iron formulation. If, say, develop urticaria, treat with antihistamine and/or corticosteroids. Another adverse reaction is hypotension. Hypotension is a hypersensitivity or vascular reaction, and it is also self-limiting. It is related to the rapidity of administration and labile iron content. So, to manage this, lie the patient horizontally with leg elevation. Give IV fluid bolus 1 pint and antihistamine and corticosteroid. Another important adverse reaction is anaphylaxis, which is an IgE-mediated reaction and CARPA complement activation-related pseudo-allergy. It is also related to rapidity of administration, and fortunately, it is exceedingly rare, occurring in less than 1 in 250,000 administrations. Usually, it presents with cardiorespiratory manifestations. Therefore, treatment would be adrenaline, fluids, and corticosteroids. It is a delayed reaction, hence it can't be predicted by test dose. So these are the various IV iron preparations available in Malaysia. Commonly used in our clinic is the low molecular weight iron dextran or Cosmofer. So when should we consider IV iron? We should consider parenteral iron when patient has not responded to oral hematinics, and we have maximized our oral hematinics and dietary modifications. We should also consider when there is an urgency to top up hemoglobin, such as before surgery or delivery. And we should also consider when massive bleeding is anticipated, as well as to any pre-op, intra-op or post-op procedure. So how to calculate the iron requirement? To calculate the dose of iron required, we can either use oxygen delivery formula or oxygen utilization formula. But I do think that we are more familiar using the oxygen delivery method, right? For oxygen delivery, we use the target HB of 11 grams per deciliter. Now this is the same formula applied in our previous perinatal care manual and Gansoni formula. Meanwhile, in oxygen utilization formula, we are using the serum ferritin and it is targeted at the level of 100. This is an example of calculation for measuring oxygen delivery. Let me give you an example of a patient with a hemoglobin level of 9.5 grams per deciliter and serum ferritin of 4 with her body weight as shown in the slides. So using Gansoni's formula for oxygen delivery, first, let's calculate the hemoglobin deficit by subtracting the current level of HB from the target level of 11. Her current HB is 9.5. Therefore, her HB deficit is 1.5. Normal iron stores is at a fixed estimation of 500 milligrams. So the formula for total iron dose is equivalent to body weight in kilograms multiplied with HB deficit multiplied with 2.4 and finally addition to normal iron store, which is the 500 mg. Therefore, the total iron required for her is 788 milligrams. So since 1 ampule is 100 milligrams of iron, so she will require about 8 ampules of parenteral iron.
So either intravenous infusion, bolus, or intramuscular boluses.
This is a general comparison between iron deficiency anemia and anemia of chronic disease. It shares many similarities, and some differences are probably a normal level of MCV and ferritin. A key investigation that might differentiate these two is erythropoietin level, which may be inappropriately low for the degree of anemia in anemia of chronic disease. And the inflammatory markers and hepcidin could be raised. However, the availability of these investigations would require discussion with the physician and hematologist. Regarding thalassemia, thalassemia is the most common genetic disorder amounting to 4.5% of world population. About 4 to 6% of Malaysians are carriers, with Sabah having the highest carrier rate of beta thalassemia. Coming to beta thalassemia, it is caused by impaired production of beta globin chains. The different types are beta thalassemia minor or trait or silent carrier, beta thalassemia intermedia, and beta thalassemia major. During pregnancy, women with beta thalassemia trait sometimes exhibit a tendency to develop a more profound physiologic anemia of pregnancy than normal mothers and may require transfusion. However, pregnancy outcomes are generally favorable. Beta thalassemia 2 can occur concurrently with iron deficiency anemia, and this needs to be investigated and treated first. Usually, we will review the FBC and they share very similar picture with IDA, and significant difference would be the RDW, which might be raised in IDA. Hence, the need to proceed with iron study to better differentiate it. Coming to beta thalassemia intermedia, it usually does not require transfusion during at least the first few years of life and are able to survive into the second decade of life without chronic hypertransfusion therapy. While they may not require transfusion therapy at all, or as often as those with thalassemia major, they still exhibit increased absorption of dietary iron and may ultimately develop signs and symptoms of iron overload. They may also suffer from the complications of chronic hypoxia, such as high cardiac output, increased pulmonary vascular resistance, pulmonary hypertension, and heart failure. In contrary, beta thalassemia major has characteristic clinical features and are transfusion dependent with iron overload. What about alpha thalassemia? Well, it is due to the impaired production of alpha globin chains. Alpha thalassemia minima shows loss of one of the 4 alpha globin gene, and in alpha thalassemia minor, loss of 2 of the 4 alpha globin gene. In HBH disease, there are loss of 3 out of the 4 alpha globin gene, and in hydrops vitalis with HB buds, there are losses of all 4 alpha globin loci. Alpha thalassemia minima is essentially asymptomatic. They are not anemic, and their red cells are not microcytic, and their electrophoresis pattern is normal. The diagnosis of alpha thalassemia minima can be reliably made only via DNA analysis. Alpha thalassemia minor resembles mild beta thalassemia trait. Some adult patients may have mild anemia, and their red cells are hypochromic and microcytic, and target cells are present. Hemoglobin electrophoresis pattern is normal. Therefore, the diagnosis can reliably be made only via DNA analysis. Alpha thalassemia HBH disease. When there is loss of 3 of the 4 alpha globin loci, it is called hemoglobin H disease. HBH disease exhibit all of the stigmata of chronic hemolytic anemia, including hepatosplenomegaly, indirect hyperbilirubinemia, elevated LDH, reduced haptoglobin, leg ulcers, and premature biliary tract disease. It resembles patients with beta thalassemia intermedia. Even though transfusion support is not necessary early in life, splenectomy or institution of transfusion support during the second or third decade of life is often necessary. How the thalassemia trait is inherited. Both alpha and beta thalassemias are often inherited in an autosomal recessive manner. When one parent is a carrier, the risk of child to have thalassemia is 0%, but have 50% of chance of becoming a carrier. When both parents are carrier, the risk for the child to have thalassemia is 25% and 50% chance of becoming a carrier. When one parent is a thalassemia patient and the other is a carrier, the risk for the child to have thalassemia is 50% and 50% chance of becoming a carrier. And when both parents is a thalassemia patient, the risk for the child to have thalassemia is 100%. So, in general, if pregnant mother is a thalassemia carrier, screen untested partner with FBC. If both are carrier, they should be counseled and offered prenatal diagnosis by referring them to the ONG. Screening should also be done to those who had not completed cascade screening in their family. All thalassemia major patients will require follow-up under fetal-maternal or ONG combined with hematologist in view of risk of iron overload complications. Iron therapy will only be offered for thalassemia carrier patients with concurrent IDA and to maintain hemoglobin levels of more than 7 grams per deciliter. So generally, during antenatal follow-up, thalassemia patients in pregnancy should be monitored regularly of their hemoglobin levels. If anemic, check serum ferritin, and for iron supplement if serum ferritin is less than 30. Folic acid should be given throughout pregnancy similarly. Do refer to ONG if the hemoglobin level is less than 7 grams per deciliter or symptomatic of anemia. The delivery plan would be to aim hemoglobin more than 7 grams per deciliter, and generally they can be allowed post-date unless specified otherwise. If moderate or severe anemia, to be delivered at specialist hospital and to give PPH prophylaxis. During postpartum, refer baby to pediatrics at delivery if both parents are carriers. If only the mother is a carrier, the baby should be seen at 6 months old in health clinics. And contraception options should be discussed with the couple. If it is a newly diagnosed thalassemic couple, pre-pregnancy counseling should be done.
Finally, to conclude, a bring to work message. Iron deficiency or iron deficiency anemia is an important modifiable factor. Therefore, early investigation and treatment of iron deficiency before progressing to IDA is vital. Consider screening ferritin and transferrin saturation, and not just hemoglobin levels, to diagnose iron deficiency or iron deficiency anemia, especially those with a microcytic pattern. Remember, EOD oral iron is for prophylaxis. Daily oral iron is for treatment. Resort to IV iron if patient does not respond to oral hematinics so that we can treat mother and prevent anemia in the unborn fetus. In postpartum anemia, use IV iron for faster response. Anemia is a risk factor for PPH. With proper PBM, it prevents, reduces, and manages PPH well. We should start providing option for IV iron in KK setting or collaborate with the nearest district hospital. Thalassemia carrier need to screen the partner while thalassemia carrier couple requires prenatal diagnosis. With that, thank you.